Rachel Maskell.
Thank you, Madam Deputy Speaker. I beg to move amendments 26, 45 and 46 in my name and other members, and I'm grateful for their support. Briefly on Amendment 26, hospice care is not a formulation of care, but a clinical setting where palliative care is delivered, so I trust the House will accept my amendment for accuracy. Now let me turn to Amendment 45 and consequential Amendment 46. The literature points to a complex clinical decision-making, of which this is being safer if made in the context of multidisciplinary teams, as advocated for by the professional bodies at the very start of the process. Further, it screens out unconscious bias and provides for clinical accountability with robust interdependency. It demands a deliberative process and safeguards clinicians and patients with more secure outcomes. I've talked extensively to the professional bodies, clinicians, and read the academic evidence on this. And in drawing out best practice, this amendment will provide such safeguards, ensuring that the patient is at the heart. Honourable members will know from the evidence to the Bill Committee that this initial assessment is the most important part of the process, and clinicians and professional bodies do not understand why psychiatrists and social workers are placed in a quasi-judicial role rather than to use their clinical and social expertise. The process makes the wrong assumptions without this change. There's a predication towards an assisted death, rather than recognising the insecure position that someone with a terminal illness finds themselves having and the safeguards that are required. There are many reasons for suicidality, and they should be explored. In clinical practice, should someone determine that they want to end their life for whatever reason, then a clinician would seek to ensure that right professionals were involved in the care of the person with exploration, diagnosis, and where necessary, therapeutic and pharmacological interventions. I won't. Dr. Ladi Smith, the President of the Royal College of Psychiatrists, could not have been clearer. Academic research says the same. When someone is in receipt of a terminal diagnosis, there is frequently an episode of depressive disorder. Dr. Price presented evidence that those who had a wish to hasten death were 18 times more likely to feel suicidal. They say mental disorders are treatable. The spike in suicidal ideation and action is highest in the first few months following terminal diagnosis and then dissipates with time or intervention. Again, evidenced. People change their mind, no longer wanting to die. As with other aspects of the bill, poor care, poor pain management and poor symptom control, or the fear thereof, is why someone seeks to end their life. This can be palliated. Colleagues must recognise the paucity of mental health provision given to somebody when they receive a terminal diagnosis. Often no psychological aftercare. People failed, yet this should not be a reason to die. So I ask for a panel with a social worker to assess the psychological needs of a patient, experts in being able to detect coercion, intrinsic and extrinsic, understanding people that are the most vulnerable, and a fusion of complex emotions, anxiety and fear. Solutions can be found by them. Then a psychiatrist. Depression, anxiety and fear are natural responses to trauma. However, can be treated with the right interventions. It detects at the point somebody expresses a wish to die. Then a person can have a wish to live. The travesty of getting this wrong is unconscionable. Then a palliative care consultant registered on the GMC Specialist Register, understanding the very actions that can alleviate somebody's suffering. Evidence at the Bill Committee from Sue Ryder showed how poor provision led to somebody's consideration of an assisted death. Likewise, President of the Association of Palliative Medicine, Dr. Sarah Cox, set out, and I quote, "We know that effective palliative care can change a terminal ill person's point of view from wanting to die to wanting to live." Evidence. A point I have heard from all leaders of on our Palliative Care Commission. These are the specialists who know how to palliate physical, psychological, socially and spiritual needs of a patient. And they have such techniques which many people have not had access because of poor provision. In our Palliative Care Commission, which reported on Tuesday, and please read the evidence-rich report drawn from best practice, we reported excellence in end-of-life provision is achievable. Too many people are just not getting access. Without this, I fear the bill not only leads the patient down one route, that to die, and this is not choice at all. It's a path to an assisted death. Then I asked for 2 doctors, a generalist and a specialist, one of which is the coordinating doctor. Yesterday, the Royal College of Physicians stated that there is inadequate protections of patients and professionals in the bill, and I quote, "Notably, the proposed mechanism of decision-making are not in line with good clinical and professional practice. Parliament must address these critical issues in the legislation or risk failing to protect vulnerable patients and uphold the integrity of clinical practice." End quote. This week, the chair of Royal College of GPs has said they've got real concerns about the practical and legal implications within this bill. And I seek to address that assessment process with my amendment. But I must quickly say to the Minister, if he thinks just 2 days of training for a doctor is sufficient, well, I can tell him they will not have the necessary competencies. But it even suggests in the impact assessment it will just be 90 minutes online with 60 minutes interactive training. That is simply not good enough. Poor medicine makes assumptions, and this bill certainly does. It assumes somebody wants to die. However, it's a clinician's duty to have an open and inquiring mind, to seek out reason, not to assume, not least when government's suicidal prevention strategy recognises such. It is only through examination can we establish why someone wants to die. And Chapter 8 of the Palliative Care Commission reports that 24% of the population know very little or have not heard of palliative care, as set out by the King's College study. The bill only presumes an assisted death, not choice. Finally, how to do this? Separate or joint assessments, and then a panel meeting to deliberate. So not a quasi-judicial panel, but evidence-led assessment where real choice is offered. Listen to the experts, hear their collective voice. This bill is unsafe. It is why the professional bodies are speaking out against this bill. While my amendment will nudge it into a safer place, the scale of concern far exceeds this. Colleagues, we must follow the experts' evidence.
Sir Jeremy Wright.